Candida is a yeast, not the maple syrup loving country in North America. Although Candida can be found in Canada as well. Candida sometimes causes a mild yeast infection, but in some situations it can get into the bloodstream and cause severe illness. Now, there are various types of Candida species, and over 20 of them can cause disease in humans. There's C. albicans, C. parapsilosis, C. tropicalis, C. glabrata, C. cruce, C. auris, and the list goes on. Of these, the most common one is C. albicans. Candida is found throughout the body. It likes warm, moist environments like the mouth, the diaper region of babies, and in women it can be found in the vagina. Now, it's normal for microbes like bacteria, fungi, and viruses to live all over the body, but each microbe is slightly different in terms of whether it's colonizing the body, in other words, just living and not causing any problems, or whether it's infecting the body, which is causing some degree of tissue damage or destruction. An important factor is exactly how much of a microbe is present. Candida is considered an opportunistic microbe. When the amount of Candida is relatively low, it's harmless. But if a person's immune system is weakened, or if there's less competition for the Candida, then the amount of Candida can increase, and that's called Candida overgrowth. Now, Candida can exist in multiple forms. It's kind of like a chameleon. All Candida species can take on a round or oval shape, and these are called yeast cells. One Candida species, called Candida albicans, can also appear like pseudohyphae, where it looks like long thin filaments, kind of like a segmented cactus plant. So these two shapes of Candida albicans express different protein profiles, and they give the cells different properties. In yeast mode, Candida is better at moving from one part of the body to another, whereas in filamentous mode, it's better at invading tissues. Candida typically lives on the skin or mucous membranes, and when it starts to overgrow, it can damage nearby tissue. With this, there are a few patterns of injury. The most common one is pseudomembranous candidiasis, and it's primarily due to a weakened immune system that allows for Candida overgrowth. The result is destruction of the stratified squamous epithelium layer, which is the outermost layer of the skin or mucous membranes. This causes accumulation of the destroyed cells in the keratin protein that fills the outermost layer, forming a white lesion called a pseudomembrane that looks kind of like cottage cheese. The white lesions aren't typically painful, and they can be scraped away with a tongue depressor, leaving behind a red mucosal base which sometimes bleeds. Since the underlying cause is a weakened immune system, it's fairly common in young infants and the elderly, both groups that have a relatively weak immune system. It can also be related to an immunosuppressive condition, like diabetes or HIV, or from immunosuppressive medical treatments, like steroids, including inhaled steroids, as well as radiotherapy or chemotherapy. Another pattern of injury is called erythematous candidiasis, and that typically results from a change in the levels of microbial competition keeping Candida in check. For example, a course of antibiotics or tobacco smoking, which both selectively destroy certain bacterial populations more than they affect Candida. The opposite is true as well. Sometimes there are mechanical devices like braces that favor Candida growth more than the growth of other microbes. In either situation, the result is an overgrowth of Candida, which causes increased blood flow to the affected tissue with red, painful lesions. In a lot of situations, there's a mixed pattern of injury, with both a pseudomembranous and erythematous component. Candidal infections can affect various parts of the body. The most common location is in the mouth, where it causes thrush, which is usually a pseudomembranous candidiasis. So classically, it looks like white cottage cheese on the buccal and gingival mucosa. Candida can also affect the esophagus, resulting in an esophagitis that can cause pain with swallowing. Candida can affect the diaper region of babies, causing a diaper rash with redness surrounded by scattered red spots that are called satellite lesions, because they look like tiny red satellites that are not contiguous with the rest of the rash. Another common one is vulvovaginitis, commonly called a yeast infection in women, and it can cause vaginal itching and discharge as well as pain while urinating. Now, in addition to local infections, Candida can cause more serious invasive infections, and these often develop in individuals that have underlying immunodeficiencies. Other risk factors for serious candidal infections include hyperglycemia and reduced stomach acidity. The most common situation is an infection of a prosthetic device like a central venous catheter. In these settings, Candida forms a biofilm, which is where the yeast lives inside a jelly-like matrix of proteins and behaves more like a large colony than like a collection of individual cells. Candida is able to infect devices, and if the infection isn't treated, then over time, small clumps of the yeast-laden biofilm can break away, get into the blood, and cause candidemia. From the blood, Candida can spread to other locations, which is known as invasive candidiasis. Commonly affected sites are the heart valves, the liver, and spleen, as well as the bones and joints. Candida can also cause kidney infections, either as a complication of candidemia or as a complication of urinary tract infection. Candida can also cause meningitis, in particular if it infects a device in that space, like a ventricular shunt. What's more is that Candida can cause particularly worrisome infections of the eye. Diagnosis of oral candidiasis can be confirmed with a culture, and ultimately a tissue biopsy might be done in some cases as well. For invasive infections, the gold standard of diagnosis is a positive blood culture, but blood cultures can be negative a lot of the time. Alternatively, antigen testing can also be done. For example, one test looks for a cell wall component called beta-D-glucan, which is found in Candida and a few other fungal species. Another test is Candida PCR, which detects candidal DNA. Treatment of candidiasis depends on the location and severity of the infection. Oral thrush is treated with oral nystatin suspension, whereas vulvovaginitis and skin infections are treated with topical antifungals. Resistant infections are often treated with azole antifungal medications. In severe infections, especially when there's a prosthetic device like a catheter or a ventricular shunt that's infected with a biofilm, it's often necessary to remove the device. Severe infections are often treated with a medication like amphotericin, azole antifungals, or echinocandins like micafungin. Alright, as a quick recap. Candida is an opportunistic fungus that can overgrow in situations where there are fewer competitive microorganisms or a weakened immune system. Common sites of infection include the mouth, the esophagus, the vulvovaginal region, and the groin in infants. These superficial infections are usually treated with nystatin, or topical antifungals. Severe infections include those where a biofilm forms over a prosthetic device, and typically require removal of the infected device.
Human herpes virus 6, or HHV6, is a double-stranded DNA virus, which belongs to the herpes viridae family, subfamily Beta herpes viridae, genus Roseola virus. HHV6 primary infection is the cause of the common childhood disease called Roseola infantum, also known as exanthema sibitum, or sixth disease. Human herpes virus 6 is a double-stranded linear DNA virus surrounded by an icosahedral capsid, which is a spherical protein shell made up of 20 equilateral triangular faces. The capsid is covered by a protein layer called tegument, and enclosed in an envelope, which is a lipid membrane that contains viral glycoproteins and is acquired from the nuclear membrane of host cells. Now, HHV6 infection begins when a person comes in contact with respiratory secretions from another person who contains the virus. Once in the body, the virus attaches to dendritic cells, which are antigen-presenting cells that can be found in the skin, nose, lungs, stomach, and intestines. These cells are able to process antigens like viral proteins and present them on the cell surface to the T cells. So when the virus attaches to dendritic cells, it activates them, and they migrate to the lymph nodes, where they interact with CD4 positive T lymphocytes. When dendritic cells and T cells interact, the virus gets ingested by T cells, and they get infected. Inside T cells, the virus can replicate most efficiently. So it undergoes the lytic cycle, where its DNA gets transcribed and translated by cellular enzymes to form viral proteins, which are packaged into new viruses that leave the cell destroyed and subsequently infect neighboring cells. The virus can also replicate into a wide variety of other cells, such as monocytes, macrophages, natural killer cells, astrocytes, megakaryocytes, and glial cells, but not as efficiently as inside T cells. Finally, HHV6 can go into a latent state in monocytes, where the virus just hangs out inside the cell instead of killing it. This may sound harmless, but in people with immunosuppression, especially after a bone marrow or organ transplant, the virus can reactivate and cause serious infections, such as encephalitis. Most often, though, HHV6 causes a disease called roseola infantum, which usually occurs in young children aged between 6 months and 2 years. The disease has an incubation period of 1 to 2 weeks. After the incubation period, the disease debuts with a high fever that may exceed 40 degrees Celsius or 104 degrees Fahrenheit, and usually lasts 3 to 5 days. During the febrile phase, other manifestations include periorbital edema, acute otitis media, rhinorrhea, or a runny nose, cough, vomiting, diarrhea, a bulging fontanelle, cervical, occipital, or postauricular lymphadenopathy, and Nagayama spots, which are small red spots on the soft palate and uvula. After the fever goes away, a maculopapular rash appears, which is when pink or red spots develop. They appear on the neck and trunk first, and then spread to the face and extremities. The rash usually lasts 1 to 2 days, but sometimes it may go away within as little as 2 to 4 hours. Roseola is usually diagnosed based on clinical findings. The presence of HHV6 can be demonstrated by cultivating the virus, using PCR to identify viral DNA from clinical samples such as blood, cerebrospinal fluid, or respiratory secretions, and also by demonstrating a rise in IgG antibodies against HHV6. Treatment is usually supportive since roseola is a self-limiting disease. Fever can be controlled with antipyretics such as acetaminophen or ibuprofen, and in case of vomiting or diarrhea, fluid intake should be increased to prevent dehydration. The rash goes away without treatment. In severe cases, like HHV6 infection in individuals with immunosuppression, antivirals like acyclovir or ganciclovir can be given. Alright, as a quick recap, human herpes virus 6 is a double-stranded DNA virus that replicates most efficiently in CD4 positive T lymphocytes. In young children, it causes a disease called roseola infantum, which is characterized by high fever that lasts 3 to 5 days, and a rash that develops after the fever disappears. Diagnosis is usually based upon clinical presentation, and treatment is usually supportive. But in severe cases, antivirals like acyclovir or ganciclovir can be given.
Measles is one of the most contagious infectious diseases and remains a leading cause of death, particularly among young children, especially in areas with low rates of vaccination. Measles is also called rubeola, which can easily get confused with German measles, which is also called rubella. Similar sounding names, but very different viruses. Regular measles is caused by the measles virus. Seriously, the species is the measles virus, of the genus Morbillivirus, and family Paramyxoviridae. The reason why this guy's so contagious is that it's airborne, and spreads via tiny liquid particles that get flung into the air when someone sneezes or coughs, and can live for up to 2 hours in that airspace or nearby surfaces. If someone breathes in that air or touches a surface and then touches their eyes, their nose, or their mouth, they can become infected. Measles is so contagious that if one person has it, 90% of nearby non-immune people will also become infected. Once the measles virus gets onto the mucosa of an unsuspecting person, it quickly starts to infect the epithelial cells in the trachea or bronchi. Measles virus uses a protein on its surface called hemagglutinin, or just H protein, to bind to a target receptor in the host cell, which could be CD46, which is expressed on all nucleated human cells, CD150, aka signaling lymphocyte activation molecule, or SLAM, which is found on immune cells like B or T cells and antigen-presenting cells, or Nectin-4, a cellular adhesion molecule. Once bound, the fusion, or F protein, helps the virus fuse with the membrane and ultimately get inside the cell. Now, this virus is a single stranded RNA virus, and it's also negative sense, meaning it first has to be transcribed by RNA polymerase into a positive sense mRNA strand. After that, it's ready to be translated into viral proteins, wrapped in the cell's lipid envelope, and sent out of the cell as a newly made virus. Within days, the measles virus spreads through local tissue and is picked up by dendritic cells and alveolar macrophages and carried from that local tissue in the lungs to the local lymph nodes. From there, it continues to spread, eventually getting into the blood and spreading to more lung tissue, as well as other organs like the intestines and the brain. Now, it typically takes 10 to 14 days from the time that the virus enters the body to the start of symptoms, and this is the incubation period. Once the symptoms start, we've entered the prodromal period, which typically lasts around 3 days and starts with a high fever and the 3 C's: cough, conjunctivitis or inflammation and redness of the white part of the eye, and coryza, swelling in the mucous membrane of the nose, essentially a stuffy nose. 1 to 2 days later comes the enanthem, which is a rash on the mucous membranes that looks like salt grains on a wet background. These are called Koplik spots and are these small white spots that are commonly seen on the inside of the cheeks opposite the molars. After these initial prodromal symptoms comes the exanthem phase, which is where a red, blotchy, maculopapular rash spreads in a cephalocaudal progression. In other words, the exanthem starts at the head, or cephalo, and spreads to the extremities, or the ends of the body, or caudal. This rash fades after about 4 days, and leads into the recovery phase, which can last for another 10 to 14 days, with the final symptom usually being a persistent cough. In general, infected people are most contagious starting from the final day of the incubation period through the prodromal and exanthem phase, which roughly works out to be 4 days before to 4 days after the onset of the rash. Now, the good news is that once all this is over and someone's recovered from measles, they have lifelong immunity. Since measles affects various organs like the lungs, the intestine, and the brain, it can lead to complications like pneumonia, diarrhea, and on rare occasions, encephalitis, all of which can lead to death. In addition, measles can suppress the immune system for up to 6 weeks, and this can contribute to bacterial superinfections like otitis media and bacterial pneumonia. All of these complications are worst among young infants, who typically have the highest rates of mortality during a measles outbreak. Another severe and often fatal complication for children under 2 years old is the development of subacute sclerosing panencephalitis, which can happen 7 to 10 years later. And this is thought to be caused by persistent measles virus infection, possibly due to an abnormal immune response or a mutated strain of the measles virus, which leads to chronic inflammation of the entire brain. The symptoms of SSPE are initially pretty subtle, like, for example, mood changes, but eventually become severe and dramatic, and can include seizures, coma, and if left untreated, death. For people who are immunocompromised, for example, people with HIV or AIDS, their immune-mediated responses are impaired. That being said, if they get measles, they might not develop some symptoms that are a result of the immune system responding to the measles virus, like the enanthem or the Koplik spots, or the exanthem, the rash. These people, though, also have higher rates of pneumonia and encephalitis, which contribute to a higher mortality rate. Diagnosis of measles is usually done via serology, looking for measles antibodies in the blood serum, and the disease is usually most likely to happen with unvaccinated individuals. That said, the measles vaccine is a live attenuated immunization, essentially meaning it's been weakened, and it's given between 12 and 15 months of age, and again between 4 and 6 years of age. And it has an impressive 95% vaccine efficacy rate, which means that out of 100 cases of measles among unvaccinated people, 95 would have been prevented by the vaccine. In addition to the vaccine, another source of protection for young infants is their mother's anti-measles antibody, or immunoglobulin, which the fetus gets transplacentally and lasts until about 9 months of age. When measles does develop, there isn't a specific antiviral treatment. Instead, the medications are generally aimed at treating superinfections, maintaining good hydration with adequate fluids, and pain relief. Some groups are also given vitamin A, like young children and the severely malnourished, which acts as an immunomodulator that boosts the antibody responses to measles and decreases the risk of serious complications. Finally, in outbreak settings, measles vaccine can be given to household contacts, and measles immunoglobulin can be given to pregnant women and young infants to help prevent others from getting sick. Alright, so quick review of measles. Measles is an airborne pathogen that's highly contagious and causes cough, conjunctivitis, and coryza, as well as complications like pneumonia and encephalitis, and can be prevented through vaccination. Parvovirus B19 is the smallest known DNA animal virus, coming in at a tiny 18 to 28 nanometers in diameter. In comparison, the average size of a single human red blood cell is a whopping 7,200 nanometers. While it's mostly known for causing fifth disease, or slap cheek syndrome, in children, parvovirus B19 can also affect adults, and it can cause serious illness in individuals with pre-existing conditions like sickle cell anemia and HIV. Parvovirus B19 is part of the Parvoviridae family. It's a single-stranded DNA virus surrounded by an icosahedral capsid, which is a spherical protein shell made up of 20 equilateral triangular faces. And it's naked because the capsid is not covered by a lipid membrane. Parvovirus B19 is primarily transmitted by respiratory droplets when someone coughs or sneezes. You can also catch it via an infected blood transfusion, and a pregnant female can also transmit it through the placenta to her unborn child. Now, although the virus first enters cells through the respiratory tract by binding to receptors on host cells, it does not replicate in them. Instead, it keeps traveling through cells and into the circulatory system until it reaches the bone marrow, where red blood cells are made, a process called erythropoiesis. Once there, parvovirus B19 uses receptor-mediated endocytosis to enter erythroid progenitor cells, also called proerythroblasts, the early cells that eventually become red blood cells. It then uses these cells' DNA replication machinery in the nucleus to replicate its DNA and assemble new copies of the virus. Why not simply replicate in cells of the respiratory system? Well, it turns out that parvovirus B19 needs two things. It prefers to bind to a specific receptor, the P antigen, which is found in large numbers on proerythroblast cell membranes, and it needs cells that pass through the S phase of the cell cycle, which is the phase where cell DNA is replicated. Since the body is constantly producing new red blood cells, there are always proerythroblasts going through the S phase at any given time. As the virus replicates and matures, it produces a protein called non-structural protein 1, or NS1, which is toxic to human cells and causes apoptosis, or cell death. This means that erythropoiesis breaks down, and fewer new red blood cells go into circulation as a result of parvovirus B19 infection. But thankfully, this is only temporary. When the cell dies, it bursts open, releasing copies of the virus into the blood, also called viremia. Our immune system detects the virus and starts producing specific immunoglobulin M and immunoglobulin G antibodies to fight the infection by forming immune complexes with the parvovirus B19 antigen. For individuals with a functioning immune system, this typically happens between 10 and 14 days after first becoming infected with the virus. Parvovirus B19 is most common in young children and those who live or work with them, like parents, siblings, and daycare workers. Fetuses are at risk of parvovirus B19 if their pregnant mother has never had the virus in the past. Immunocompromised individuals are also particularly at risk of chronic parvovirus B19 infection, since their immune system cannot mount an appropriate response to the virus. The incubation period for parvovirus B19, basically the period before viremia starts, is between 4 and 14 days, after which symptoms develop. Flu-like symptoms, like a mild fever, headache, and aching muscles, are most common during viremia. Once the immune response begins and the viremia ends, these symptoms go away, and some individuals will then develop a rash and/or joint pain. The rash appears as uniform redness of the cheeks, but not the area around the mouth, giving the classic fifth disease slap cheek appearance. A lace-like rash might also appear on the trunk and the limbs. Joint pain and inflammation, or arthralgia and arthritis, linked to parvovirus B19 infection usually affects the small joints of the hands, wrists, feet, and knees, and are often symmetrical, meaning that the same joints on both sides of the body will be affected. Children tend to get the rash, whereas adults are more likely to develop joint pain, but it's not exclusive to either group. There are a few complications caused by parvovirus B19 infection. The decreased red blood cell production can cause transient aplastic crisis in individuals who have underlying conditions like sickle cell anemia, hereditary spherocytosis, and thalassemia. Because they already have fewer red blood cells, the breakdown of erythropoiesis results in severe anemia, with symptoms like pale skin, fatigue, and weakness. Parvovirus B19 in a pregnant female can cause anemia in her fetus. Because there are fewer red blood cells to carry oxygen, the heart will pump a larger volume of blood to give the growing fetus all the oxygen it needs. This raises the pressure inside blood vessels, and fluid can start to leak out of the capillaries as a result. This can result in hydrops fetalis, or the abnormal accumulation of fluid in soft tissues. Fetal anemia is also linked to fetal loss, particularly if the parvovirus B19 infection is in the first half of the pregnancy. The good news is that there are no fetal defects associated with parvovirus B19 for those fetuses that survive the infection. Lastly, immunocompromised individuals, like organ transplant recipients and people with HIV, can develop a serious complication from parvovirus B19 called pure red blood cell aplasia. This is a form of chronic, severe anemia where there are very few immature red blood cells in circulation in blood vessels or erythroid progenitor cells in the bone marrow. Symptoms of pure red blood cell aplasia are similar to other forms of anemia, like lethargy and malaise. Parvovirus B19 infection is usually diagnosed by clinical examination. Blood tests looking for antibodies to the virus, specifically immunoglobulin M and immunoglobulin G, are reserved for atypical presentations of the virus and for pregnant individuals. Another option is polymerase chain reaction, or PCR, which looks for viral DNA. It's the preferred diagnostic method of parvovirus B19 infection in immunocompromised individuals, who typically do not have high IgM or IgG levels in response to an infection. PCR can also be used on amniotic fluid to diagnose infection in a fetus. When it comes to treatment for parvovirus B19 infection, it varies based on the symptoms. Fifth disease is usually mild and gets better on its own, while a transient aplastic crisis often requires transfusion of blood products. Arthralgia and arthritis are treated with NSAIDs and usually resolve on their own. Chronic infections in immunocompromised individuals are treated with immune globulin intravenous therapy, or IVIG, which involves giving antibodies, mostly immunoglobulin G, taken from donor blood plasma. Severe anemia in a fetus between 18 and 35 weeks of gestation can be treated with an intrauterine blood transfusion. Before 18 weeks, the procedure is too difficult technically. After 35 weeks, risks of transfusion are high compared to simply delivering the baby. Finally, there's no vaccine for parvovirus B19. Preventative measures include proper hand washing with antiseptic soap and water, and sanitizing surfaces that would have come into contact with respiratory droplets, since the virus can survive on surfaces. Alright, as a quick recap. Parvovirus B19 is a single-stranded DNA virus of the Parvoviridae family. It infects and replicates in erythroid progenitor cells in the bone marrow. Viral replication results in apoptosis of infected cells. It's transmitted by respiratory droplets. Flu-like symptoms are common during the viremia phase of the infection, followed by a slapped cheek rash and/or joint pain. Children are more likely to show the rash, and adults tend to have the joint pain. Parvovirus B19 can cause transient aplastic crisis in individuals with underlying hemolytic disorders, fetal loss and hydrops fetalis in pregnancy, and pure red blood cell aplasia in immunocompromised individuals. Treatment for parvovirus B19 varies according to the symptoms, and can involve blood transfusion for transient aplastic crisis and hydrops fetalis, and immune globulin intravenous therapy for chronic infections.
Rubella, the infection formerly known as the German measles, is caused by the rubella virus. Thanks to vaccination, it's a disease we see less and less, although because some groups are under-immunized, it's still possible to see outbreaks. The rubella virus is part of the Togaviridae family. togaviruses are single-stranded RNA viruses surrounded by an icosahedral capsid, which is a spherical protein shell made up of about 20 equilateral triangular faces, all within a spherical outer lipid envelope. They're also positive sense RNA viruses, which means that their genetic material is actually mRNA, so it can be used right away by the host cell to make viral proteins. Now, the rubella virus is transmitted through respiratory droplets, which are released into the environment when you sneeze or cough on another person. Within the nasopharynx mucous membrane, the virus binds to a specific receptor on the membrane of epithelial cells. It's then surrounded by a little section of cell membrane that pinches off to form an endosome that's then brought into the cell. The low pH in the endosome uncoats the viral RNA, and the virus causes changes to the endosome. Now, when the rubella virus enters the cell, it also rearranges some of the organelles, gathering the endoplasmic reticulum, Golgi apparatus, and mitochondria around the endosome. The result is a membrane-bound viral replication complex where, like the name says, the virus replicates. So, after the virus replicates, its structural proteins are synthesized using the rough endoplasmic reticulum, and these proteins are then transported to the Golgi apparatus to be assembled and surrounded by the membrane, a process called viral budding. The new virus copy eventually exits the cell by exocytosis and enters nearby lymphatic and blood vessels, traveling to lymph nodes where it will replicate once again. From the lymph nodes, it enters the blood vessels again and spreads to various parts of the body, making its way into various bodily fluids like urine, cerebrospinal fluid, and synovial fluid of joints. Finally, the rubella virus has a cytopathic, or cell-damaging, effect that's linked to viral replication. This happens because the host body reacts to replication by causing apoptosis, or cell death, in infected cells, in an attempt to prevent the virus from spreading further. Another way that rubella can spread is from a pregnant female to her unborn child through the placenta. This causes congenital rubella syndrome in the fetus. In fact, rubella is among the most common infections that cause congenital defects in fetuses, which are grouped under the acronym TORCH. T stands for toxoplasmosis, O for other infections, like syphilis, R for rubella, C for cytomegalovirus, and H for herpes simplex. We're not exactly sure how rubella causes defects in the developing fetus, but it's possible that it causes vasculitis, or inflammation of blood vessels, which damages the vessels. As a result, there's not enough blood flow to developing organs, which can result in tissue death. It's also possible that the rubella virus slows down the process of mitosis, or cell division, in infected fetal cells. Since mitosis helps drive the development of the fetus, infected tissues might not grow properly. The timing of the infection in the mother will determine the risk of the fetus also getting congenital rubella. Congenital defects are much more common if the maternal infection happens between 4 weeks before and 20 weeks after conception. After 20 weeks, there usually aren't fetal defects, but there may be some intrauterine growth restriction, meaning the baby will be smaller than expected for their gestational age. The biggest risk factor for rubella is being unvaccinated, which is more common in countries with lower vaccination rates, and coming into contact with someone who is in the contagious period of their rubella infection, which starts about 3 days after being exposed to the virus and lasts around 3 to 4 weeks. Okay, now many rubella infections are asymptomatic, but when there are symptoms, they typically show up after a 14-day incubation period. Children tend to have fewer and milder symptoms that can last anywhere from 3 to 8 days on average. They'll usually have a low-grade fever and swelling of lymph nodes behind the ears and on the back of the head. A distinctive rash made up of little pink or light red bumps, or macules, can appear at the same time as, or a few days after, the onset of other symptoms. The macules start on the face and spread downward toward the trunk and limbs, and the rash typically clears up in about 3 days. Now, teenagers and adults who catch rubella are more likely to show symptoms and to be sick for longer. Females in this group are also more likely to get arthralgia and arthritis, or pain and inflammation in their joints as a result of rubella. These joint issues can last for a month or sometimes even longer. Rubella in pregnancy increases the risk of miscarriage, fetal death, and stillbirth. Neonates born with congenital rubella syndrome commonly have a triad of symptoms: sensorineural hearing loss or deafness, eye abnormalities like cataracts and retinopathy or damage to the retina, and congenital heart disease like patent ductus arteriosus, which is when the blood vessel that connects the pulmonary artery to the aorta during fetal development fails to close after birth. They're also often born with dermal extramedullary hematopoiesis, which is when blood cells are formed in the skin rather than the bone marrow. Because it produces red or purple spots on the skin, it's commonly called blueberry muffin rash. Congenital rubella syndrome is also associated with intellectual disability, developmental delays, behavioral disorders, skin lesions, diabetes mellitus, and an enlarged liver and spleen, which is also called hepatosplenomegaly. Diagnosis of both postnatal and congenital rubella syndrome is confirmed by laboratory tests. It's usually done with enzyme immunoassay, which tests for rubella-specific antibodies, but it can also be done with polymerase chain reaction, which looks for viral RNA. Polymerase chain reaction can be used to test amniotic fluid, which is particularly useful for diagnosing in utero rubella infection. Now, there's no specific antiviral therapy for rubella, so treatment is supportive. With congenital rubella syndrome, treatment might involve surgery to correct congenital heart defects and screening newborns for hearing and vision issues. That said, prevention of rubella is done through a vaccine, which is a live attenuated immunization, essentially meaning it's been weakened. It's given between 12 and 15 months of age, and again between 4 and 6 years of age, and it has an impressive 97% vaccine efficacy rate, which means that out of 100 cases of rubella, for people that were previously unvaccinated, 97 would have been prevented by the vaccine. In addition to the vaccine, another source of protection for young infants is their mother's anti-rubella immunoglobulin, which the fetus gets transplacentally and lasts until about 12 months of age. Alright, as a quick recap, the rubella virus is a single-strand RNA virus of the toga viruses family. The virus first infects and replicates in mucous membrane cells of the nasopharynx, then does the same thing in the lymph nodes. Viral replication prompts apoptosis in infected cells. It's transmitted by respiratory droplets. Children are often asymptomatic or might have mild symptoms like fever, lymphadenopathy, and a rash, while adults tend to show symptoms and be sick longer. Rubella in pregnancy can be very serious for the fetus, resulting in congenital rubella syndrome. In addition to a blueberry muffin rash, classic symptoms of congenital rubella syndrome include deafness, eye abnormalities, and cardiac defects. Treatment for rubella is supportive, and prevention involves a live attenuated vaccine.
Varicella-zoster virus is one of the herpes viruses, and it causes 2 diseases: varicella, or chickenpox, and herpes zoster, also known as shingles. Zoster actually refers to a type of belt used by ancient Greek warriors because of the belt-like appearance of shingles. Now, let's first talk a bit about the nervous system. It consists of 2 parts: the central nervous system, which includes the brain and the spinal cord, and the peripheral nervous system includes the nerves that fan out from the central nervous system to reach the skin, muscles, and organs. Peripheral nerves that originate from the brain are called cranial nerves, and they're in charge of motor and sensory innervation of the head and neck. A specific cranial nerve 5, is the trigeminal nerve, and it's responsible for the sensation in the face. Its sensory neurons create a nerve cell cluster called trigeminal ganglion, located in the bones on the side of the face between the eyes and ears. The peripheral nerves originating from the spinal cord are called spinal nerves. Each nerve is formed by a dorsal and a ventral root. Ventral roots contain neurons that carry motor innervation from the spinal cord to the muscles. Sensory information, like touch, temperature, pain, and pressure from the skin and other tissues, travel through first-order sensory neurons in the dorsal root ganglion near the spinal cord, then through the dorsal root and into the spinal cord, where it synapses with the second-order neurons. Now, each spinal nerve is in charge of the sensation of a specific area of the skin, called a dermatome. For example, if you step on a Lego, the pain would be carried by the S1 nerve, but if you hit your big toe on a table leg, the pain would be carried by the L5 nerve. Varicella-Zoster virus is a double-stranded DNA virus, protected by a protein coat called a capsid, which is enveloped by a lipid membrane. The virus initially enters respiratory epithelial cells, but eventually spreads to numerous cell types. It gets into all of these cells by fusing its membrane with the cell membrane and releasing the capsid inside the cell. The capsid binds to the nucleus and injects it with viral DNA, where it's copied. The viral genes are transcribed into RNA and go over to the ribosome, where they are translated into capsid proteins. The capsid and viral DNA fuse together. They go through the Golgi complex, a cell organelle in charge of packing proteins, to get their lipid membrane, and finally, the newly formed viruses leave the cell, leaving behind a dead cell. When an infected person sneezes or coughs, the viruses leave the lungs and get released into the air. The virus can also be transmitted through contact with the oral or skin lesions of the infected person. When the virus comes into contact with the respiratory mucosa or the skin of a new person, it starts replicating in the epithelial cells. It soon gets picked up by nearby immune cells and gets transported to a nearby lymph node. The virus now causes primary infection called varicella, or chickenpox, and it has two stages, primary viremia and secondary viremia. In primary viremia, the virus infects a part of the immune system in the liver and spleen called the reticuloendothelial system, which is made up of phagocytic cells. About 2 weeks after entering the body, the virus starts infecting immune cells themselves, specifically T cells, and that is considered the secondary viremia. Infected T cells start expressing proteins that bind to receptors on the skin cells. It's a bit like the virus hitching a ride in the T cell to get to the skin. Once the T cells reach the skin, they release the viruses, which start infecting keratinocytes. The infection spreads through the skin, going directly from cell to cell. Sometimes the infected keratinocytes start to fuse together and create giant multinucleated cells called Zank cells. Uninfected cells start secreting interferons alpha and beta, which inhibits viral protein synthesis and protects those cells from getting infected. As a result, we get tiny lesions on the skin separated by normal areas of skin. In addition to infecting keratinocytes, the virus also infects sensory neurons in the skin, and in those neurons it travels retrogradely, meaning backward through the neuron to the dorsal root ganglia, or, if it's on the face, the trigeminal ganglia. Over time, when the adaptive immune reaction kicks in, most of the viruses in the body are eliminated, but the ones in the ganglions are spared and can remain dormant for many years. Most commonly, the virus establishes a latent state within the trigeminal ganglia and the dorsal ganglia. Later on, if the immune system weakens due to aging, stress, or immunosuppressive therapy, the virus can be reactivated. It can then travel back up through the sensory nerve, anterogradely, to the skin and cause an infection in the innervated dermatome. That's called herpes zoster, or shingles. With both chickenpox and shingles, the most common complication is a secondary bacterial infection of the skin lesions. So, if the liver becomes infected, hepatitis can occur. If the virus spreads to the lungs, we get pneumonia. If the brain or its protective membrane, called the meninges, become infected, encephalomeningitis could occur. Symptoms of chickenpox begin about 2 weeks after it enters the body. The infection usually causes a fever, headache, and overall weakness. After a couple of days, skin lesions start to appear on the scalp, face, and trunk. At first, there are flat, red, itchy spots called macules. Over time, they become elevated and develop into papules, and then into small, fluid-filled vesicles. Within 1 to 2 days, the vesicles begin to crust over and form scabs. After about 5 days, the scabs fall off, usually without leaving a scar. New crops of lesions are continuously forming in different places on the body every 3 to 5 days, so it's possible to see lesions in different phases at the same time. In addition to the itchy lesions, painful sores can appear on mucosal surfaces, like inside the mouth. In shingles, there's typically pain, itching, or tingling in the area where the rash will develop. The rash itself is usually in a single stripe of vesicles around either the left or the right side of the body, or on one side of the face. It usually takes 4 weeks for the rash to disappear, but there can be pain in the affected dermatome which lasts for more than 90 days, called postherpetic neuralgia. Chickenpox and shingles are usually diagnosed based on the way that the skin lesions appear, but the diagnosis can be confirmed by using the Zenk test to look for multinucleated giant cells in the fluid of the vesicles. More commonly, blood tests for varicella-zoster antibodies, or PCR, can be done to look for viral DNA. Chickenpox treatment mainly includes the use of topical antipyretic medications to help reduce the itching. Also, analgesics and anti-inflammatory medications can help reduce the fever, but aspirin should not be used in someone with chickenpox because it can trigger Rey syndrome. In Rey syndrome, the liver gets affected by both varicella-zoster virus and aspirin, and it leads to a buildup of ammonia in the body. In immunocompromised individuals, antivirals like acyclovir, famciclovir, and valacyclovir can be used. In some situations, varicella-zoster immunoglobulin, or VZIG, which are anti-varicella antibodies, can be given to treat immunocompromised or pregnant individuals. Finally, varicella vaccine can be used to prevent chickenpox by helping the body mount protective immunity against a weakened form of the virus. Similarly, zoster vaccine can be used to reduce zoster, which is more common in adults. Alright, as a quick recap, varicella-zoster virus is a herpes virus that causes primary infection in the lymph nodes and secondary infection in the keratinocytes and neurons in the skin. From the neurons in the skin, it travels retrogradely to the nerve ganglia, where it remains dormant. Chickenpox is characterized by a rash on the scalp, face, and trunk that contains macules, papules, vesicles, and scabs at the same time. Herpes zoster, or shingles, is caused by the reactivation of the virus with vesicles located along one dermatome. Treatment is usually symptomatic and in some cases includes antiviral drugs.
Coxsackie virus, sometimes referred to as Coxsackie's virus, is part of the enterovirus genus of the picornavirus family, named after Coxsackie Village in New York, the place where it was first isolated. Coxsackie virus is surrounded by an icosahedral capsid, which is a spherical protein shell made up of 20 equilateral triangular faces. Nonetheless, it's a naked virus because the capsid isn't covered by a lipid membrane. It's also a positive-sense single-strand virus. This means that its RNA is actually mRNA, and the host cell ribosomes use this mRNA to make one long polyprotein chain, which is then broken into smaller pieces by viral proteases. This all happens in the cytoplasm of the host cell, since that's where the ribosomes are found, and results in several viral proteins. Coxsackie virus is primarily transmitted from person to person via the fecal-oral route. In other words, you catch it by ingesting stool particles of someone who is sick. Yuck! This can happen if infected stool ends up in the water supply or on agricultural fields, if flies land on it and transfer stool particles to other places, or by touching contaminated surfaces. You can summarize it as the 4 F's: fluid, fields, flies, and fingers. As a result, Coxsackie virus can end up in food and drinking water. It can also be spread by respiratory droplets when someone sneezes or coughs. After it enters the body, the virus first replicates in cells of the pharynx and terminal ileum. From there, the virus enters blood vessels and travels to lymphatic tissue throughout the body. This initial viral presence in the blood is called minor viremia because it's a relatively small amount of virus. Alright, Coxsackie virus counts over 24 serotypes, but they can be grouped in only two groups, A and B, based on their pathophysiology. Starting with Group A, it most commonly affects children under 5 years, and it generally prefers infecting the skin and mucous membranes. The most known serotype of this group is A16, known to cause the hand-foot-mouth disease, called so because it causes tiny blisters on those body parts. Other concerning serotypes include A25 that causes hemorrhagic conjunctivitis, and A7 that causes polio-like permanent paralysis, though it's rare. On the flip side, Group B prefers going deeper into the body, infecting visceral organs and causing problems like gastroenteritis if it affects the gut, pericarditis in case it infects the pericardium, which is that tough membrane that envelops the heart, or even causing myocarditis, which happens when it infects the heart muscle, resulting in Coxsackie virus-induced cardiomyopathy. Sometimes it travels through the bloodstream and gets into the brain, where it can cause encephalitis when it causes inflammation of brain tissue, or result in aseptic meningitis when there is meningeal inflammation. People with a Coxsackie virus infection present symptoms depending on the infecting Coxsackie group. If it's Group A, people present with symptoms of hand-foot-mouth disease that includes painful oval-shaped blisters on the fingers and palms of the hands and soles of the feet. These blisters may also be present in the mouth, throat, and tonsils in the condition known as herpangina. In the case of hemorrhagic conjunctivitis, people present with itchy, swollen eyes, appearing red due to subconjunctival bleeding. When the infection is due to a Group B Coxsackie virus, it typically causes systemic signs and symptoms, including fever, headache, and extreme fatigue. Other symptoms may vary depending on the affected organs, such as chest pain in case of pericarditis or myocarditis, and diarrhea and vomiting in case of acute gastroenteritis. If it progresses to aseptic meningitis, it typically causes a headache, neck rigidity, and pain. The diagnosis of Coxsackie virus infection is mainly based on symptoms. Laboratory investigations are reserved for severe cases. In the lab, the virus can be identified by using reverse transcriptase polymerase chain reaction, or just RT-PCR, which is a method that consists of identifying its RNA in body fluids or even having viral cultures in viable cells, but this is not routinely done. The treatment of a Coxsackie virus infection consists of supportive management, like keeping people hydrated when there are minor symptoms. In severe cases, like meningitis and myocarditis, intravenous immunoglobulin, or IVIG, is usually given. Alright, as a quick recap, Coxsackie virus is a positive-sense, single-stranded RNA virus that belongs to the enterovirus genus. It is transmitted from person to person, mainly via the fecal-oral route. Coxsackie virus is divided into two groups, A and B, based on its pathophysiological mechanisms. Group A tends to affect the skin and mucous membranes, mainly in children under 5 years, causing hand-foot-mouth disease, hemorrhagic conjunctivitis, and rarely polio-like permanent paralysis. On the other hand, Group B tends to infect visceral organs, resulting in more severe conditions like gastroenteritis, pericarditis, myocarditis, and even encephalitis and aseptic meningitis when the virus gets into the brain. The diagnosis is basically clinical, but in some cases, reverse transcriptase polymerase chain reaction is used to identify the germ's RNA in the samples. When there are minor symptoms, the management is mainly supportive, making sure that people are well hydrated, while the use of intravenous immunoglobulin is reserved for severe cases like meningitis and myocarditis.
Most of the time, when herpes simplex virus, or HSV, infects a person, there are no symptoms. In fact, it also usually moves from one person to another in the absence of symptoms. so therefore it can move through a population silently. Once in a while, though, it can cause symptoms, and typically those are in the form of skin and mucous membrane lesions, which can be divided into infections above the waist, mostly involving the mouth and the tongue, and those below the waist, involving the genitals. There are two types of herpes simplex viruses, HSV1 and HSV2, both of which are part of a larger family of enveloped double-stranded DNA viruses, the herpes viridae family. Generally speaking, HSV1 tends to cause infections above the waist, and HSV2 tends to cause infections below the waist. But there's a lot of crossover because both viruses can cause both types of infections. Although herpes is most contagious when there are virus-filled lesions present, it can also spread by asymptomatic shedding, which means that herpes viruses can be in the saliva or genital secretions even when there are no signs of a cold sore or genital lesion. Typically, when herpes virus lands on a new host, in other words, a person who's never had herpes before, it dives into small cracks in the skin, or mucosa, and binds to epithelial cell receptors, which triggers those cells to internalize the virus. Once inside, the virus starts up the Lytic cycle, which is where its DNA gets transcribed and translated by cellular enzymes, which help to form viral proteins, which are packaged into new herpes viruses, which can leave to go off and infect neighboring epithelial cells. HSV1 and HSV2 also infect nearby sensory neurons, and travel up their axon to the neuron's cell body to start up the latent cycle. The sensory neurons of the face have their cell bodies in the trigeminal ganglia, and those around the genitalia are located in the sacral ganglia. So that's ultimately where the herpes virus settles in, for life. You see, those sensory neurons aren't destroyed. Instead, they become a permanent home for the herpes virus. And from time to time, the herpes virus makes a few viral copies of itself and sends those virus particles back down the axon so they can get released and infect epithelial cells. Since the trigeminal and sacral ganglia serve just one side of the face or body, herpes vesicles and ulcers develop on the ipsilateral or same side as the affected ganglia. This can happen over and over again throughout a person's lifetime, with classic triggers being things like stress, skin damage, and viral illnesses. Recurrent episodes are usually less severe than the primary infection, and sometimes there are no symptoms at all. When there are symptoms, there might be characteristic tingling or burning sensation, called a prodrome, 1 or 2 days before the blisters appear. In oral and genital herpes, the primary infection is most often asymptomatic. Having said that, in oral herpes, when it does cause symptoms, it usually affects children, and it causes lesions on the palate, gums, tongue, lip, and facial area, as well as a fever and enlarged lymph nodes. The lesions themselves are typically clusters of small, painful, fluid-filled blisters that ooze and ulcerate, and then eventually heal after a few weeks. In older children and adults, a common symptom is pharyngitis. Most of the time, like primary infection, reactivation doesn't cause any symptoms. But when it does, the most common pattern is having a handful of blisters at the vermilion border, the border of the lip, on one side of the face. These blisters are smaller and typically heal over a week's time. With genital herpes, primary infection can cause symptoms like ulcers and pustules, which form on the labia majora, labia minora, mons pubis, vaginal mucosa, and cervix in women, and on the shaft of the penis in men. Like oral herpes, most of the time reactivation doesn't cause any symptoms. But when it does, the most common pattern is to have a few blisters that resolve rapidly in about a week. In addition to oral and genital infections, HSV can also affect other areas. When it affects the fingertip or nail bed, it's called herpetic whitlow, and this might happen if the finger rubs up against an active lesion around the mouth or genital area. Once it affects the fingertip, it's also easy for it to get carried over to other areas in the body to spread the infection, a process called autoinoculation. HSV can sometimes involve the trunk, extremities, or head, a pattern that's common among wrestlers because they have a lot of skin-to-skin contact, and is therefore called herpes gladiatorum. Finally, individuals with burn injuries or with atopic dermatitis can have really serious herpes infections in those areas. The latter even has a specific name, eczema herpeticum. HSV can also affect the eye, causing keratoconjunctivitis, which is inflammation of both the cornea and the conjunctiva. In addition to the symptoms of conjunctivitis, which are pain, redness, tearing, and sensitivity to light, there can be some classic signs of corneal involvement, like blurry vision and a branching dendritic lesion, which looks a bit like the tree-like dendrites of a neuron, which happens on the cornea itself, and this pattern is classic for herpes infection. In rare cases, herpes viruses can spread to the central nervous system and cause meningitis or encephalitis, typically affecting the temporal lobe in individuals of all ages. These can happen from a primary infection, but more commonly happen during reactivation when some of the virus can escape into the bloodstream and reach the brain. When there is brain involvement, a lumbar puncture often has specific findings like an increase in red blood cells, increase in white blood cells, and elevated protein levels. There are also some CT, MRI, and EEG changes that can help to make a diagnosis. HSV can also pass from a mother to a baby. Rather than causing a congenital infection while the fetus is in the uterus, most of the transmission happens at birth when the baby passes through the infected maternal vaginal secretions during delivery. Neonatal HSV causes 3 different patterns of illness, each happening about 1/3 of the time. The first is skin, eye, or mucous membrane infection, where lesions pop up 1 to 2 weeks after delivery, typically at sites of damaged skin, like the site where fetal scalp electrodes might have been attached. The second is central nervous system infection, which typically causes lethargy, irritability, and even seizures 2 to 3 weeks after delivery, and can cause some of the same lumbar puncture, CT, MRI, and EEG findings as that in older children and adults with HSV encephalitis. If not treated, both the first and second type can transition into the third type, which is disseminated infection, where herpes virus causes sepsis and failure of various organs, including the heart and the brain. HSV can cause unique symptoms in immunocompromised individuals, who tend to have more frequent reactivation, more severe symptoms, and a wider range of symptoms, like lesions in the esophagus or lungs. Herpes can usually be diagnosed based on how the skin or mucous membrane lesions look, and can be confirmed with tests looking for viral DNA, like polymerase chain reaction, an antibody response to the virus, or by growing the virus with a viral culture. Although infections typically resolve without treatment within a couple of weeks, there are antiviral drugs like acyclovir, famciclovir, and valacyclovir that can be used topically or systemically to reduce pain and speed up healing. For recurring episodes, these treatments usually work best if taken when the prodrome starts, in other words, before the blisters develop, and high-dose intravenous antivirals might be given in more severe or life-threatening situations. Alright, as a quick recap. Most of the time, herpes simplex virus 1 and 2 cause asymptomatic latent infections that set up in the trigeminal and sacral ganglia for life. But sometimes they can cause symptoms like recurrent oral and genital lesions. They can also cause more severe infections like HSV keratoconjunctivitis, meningitis, and encephalitis, as well as neonatal infections, which usually get transmitted when a baby passes through infected vaginal secretions. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Human papillomaviruses, or HPV for short, are a group of non-enveloped DNA viruses that specifically infect human epithelial cells. There are over 100 different types of HPVs, which can be categorized by the epithelial cells they prefer to infect, like cutaneous epithelial cells of the skin, especially the face, hands, and feet, and epithelial cells of mucous membranes, especially the respiratory tract including the pharynx and nasal and oral cavities, and anal and genital regions. Some types can cause benign tumors, called papillomas or warts, and some can lead to carcinomas, or cancer of the epithelial cells. HPV may have contributed to both actor Michael Douglas's throat cancer diagnosis and former First Lady of Argentina Eva Perón's fatal cervical cancer. Epithelial cells line the outer surfaces of organs and blood vessels, and separate the interior of the body from the external world. They primarily serve as a protective barrier to invasion by pathogenic bacteria, fungi, parasites, and viruses, and to water loss. In locations like the skin, anus, genitals, and respiratory tract, they can be stratified, having more than one layer of epithelial cells. At the base, the layer closest to the interior of the body, these cells are less mature, rounded stem cells, also called basal cells. Basal cells divide and replenish all the cells found in the epithelium. As the basal cells divide and mature, they move toward the outermost layer, flattening out and becoming more squamous shaped in appearance. Once they reach the top layer, these mature, flat cells are exfoliated or shed from the epithelium. Now, typically, basal cells are well protected under all those layers. But if there are abrasions or cuts in the epithelium, HPV can gain access to and infect the basal cells. Once that happens, HPV can replicate with or without being incorporated into the basal cell's DNA through the activities of two particular viral genes called E6 and E7. The proteins of these genes cause dysregulation of tightly scheduled replication of the epithelial cells by altering the p53 and retinoblastoma protein, or PRB, tumor suppressor pathways that typically prevent unregulated growth of the epithelial cells. In this way, HPV causes uncontrolled replication of the epithelial cells, forming warts, and disrupts the normal structure of the epithelium, forming lesions. In some types of HPV infections, a squamous epithelial cell can become a koilocyte, or a cell with an irregular shape, enlarged and dark staining nucleus, and a clear area around the nucleus that's called a perinuclear halo. These cells are typically of precancerous lesions that can transform into carcinomas when the abnormal epithelial cells break through the basement membrane of the epithelium and invade other tissues. The cause of HPV infection is contact with infected epithelial cells. Some activities can increase the risk of exposure, like having multiple or new infected sexual partners or delivering a baby through an infected birth canal. And infections are more likely if a person is already immunocompromised. Transformation to carcinoma is dependent on HPV type and is aided by other cofactors, like tobacco use, immunosuppression, and radiation. Now, many HPV infections are asymptomatic, but when symptoms are present, they can vary by HPV type. So, symptoms of non-genital cutaneous infections can involve some kind of benign wart. Common skin warts of the hands or nails are typically painless, dome-shaped projections that give the skin a rough appearance. Plantar warts on the soles of the feet can be painful and scaly, though. Flat warts of the face and extremities, particularly in the pediatric population, are often painless, small, smooth, and flat-topped, but numerous. Filiform warts of the face, particularly the eyelids and the lips, have long projections that appear thread or finger-like. And in rare cases, where there's an underlying genetic disorder called epidermodysplasia verruciformis, a chronic cutaneous infection can start out as flat warts and transform into skin cancer. Infections of mucous membranes, like the upper respiratory tract, can cause respiratory papillomatosis and can lead to voice changes and high-pitched breath sounds, particularly if the larynx is infected. Anal and genital infections, like in the vulva, cervix, vagina, penis, or scrotum, can involve numerous warts called condylomata acuminata. They tend to be skin-colored and can range in size, but have a cauliflower-like look to their surface. Though they're typically painless, they can cause itching, burning, local pain, or bleeding. Now, HPV types 6 and 11 are responsible for the majority of laryngeal papillomatosis and genital warts, but they're considered low-risk HPVs because they don't tend to progress beyond warts. But high-risk HPV types like 16 and 18 have a high risk of transforming into cancers of the cervix, vagina, vulva, penis, anus, or upper respiratory tract over 1 or 2 decades. Warts are used to diagnose HPV, particularly in cutaneous infections. Infections of mucous membranes may require additional interventions to visualize epithelial cells. An endoscopy, a tube with a camera at the end, may be needed if an infection of the upper respiratory tract is suspected. And regular PAP or acetic acid tests of the cervix after 21 years old, even if symptoms are subclinical. But a definitive diagnosis of HPV cannot be made without molecular testing of biopsied cells for viral DNA or RNA. Therefore, treatments often center around removal of warts and precancerous lesions with salicylic acid products, liquid nitrogen cryotherapy, or laser or surgical removal. In cases of frequent reoccurrences, immune modifiers may be used to help boost the immune system to remove the infection on its own. Most HPV infections can resolve on their own over time, particularly with low-risk types and in younger people. But really, prophylaxis against infection is the best course. However, limiting contact with potentially infected persons or receiving the HPV vaccine before first exposure to an infection source can also be protective against several strains, including high-risk types 16 and 18. Condom use should also be considered a measure of prevention. Alright, as a quick recap. Human papillomavirus is a DNA virus spread through contact that infects human epithelial cells of the skin and mucous membranes. Symptoms can range from warts to precancerous lesions and carcinomas. Definitive diagnosis can be made molecularly, and treatment can range from allowing the immune system to clear the infection to mechanical or chemical removal of infected cells.